because it's very seldom that we hear that ASN is a great clinician and a doctor. So thank you.
Thank you, Vikram. I appreciate that, and thank you for inviting me. After talking to Vikram, I decided I'm kind of doing something I haven't done is rather than talk about one specific topic, I'm going to do an overview, which means that I'm bringing about 25 years and about 10 different talks into one talk. So we'll see if it works. If you're a betting person, it's probably even money. But hopefully the lunch is good. So I'm going to cover kind of home hemodialysis, where we've been, where we are, and just some brief points about where we might be going. One thing is that, and the reason I bring this up is because almost anything you talk about in dialysis in general, including home hemodialysis, there's something in all of this that comes back. And Vikram and I were talking about this morning. That there's, why are we doing it this way, or why did this happen? Or when we were talking with the dialysis nurses today, why can't we do staff-assisted care? And it almost comes back to kind of the unique aspects of some of the things that we experience here in the United States dialysis. And also then, when you're sitting with your cardiology friends and they tell you how easy nephrologists have it, all you guys do is sit at your desk and put in CVVH orders. You can say, no, actually, there's a lot going on. But Medicare it was the only diagnosis-based qualification for Medicare coverage for the last 50 years. And there's several good books written about that whole process in the early 1970s that was passed to establish the ESRD program. So one of the reasons that it's hard to change the ESRD program is it's an act of Congress. So people will say the euphemism, that will take an act of Congress to change. In dialysis, that will take an act of Congress to change. Sometimes it's not just Medicare. First capitated payment by Medicare was dialysis in 1992. First bundled payment by Medicare for any orthopedics and dialysis, 2011. First pay-per-performance, 2012, nephrology. First quality rankings, dialysis, 2015 with the QUIP. First disease-specific accountable care organizations, 2016 with the ESCOs. First elective value-based programs with the CKCC and Kidney Care First. First mandatory value-based programs with the ETC, 2002, and now you have the IOTA coming. First disease-specific Medicare Advantage programs, 2023, were with kidney. Then you have the other little unique aspects, which is 70% of all of the dialysis performed in the United States is by 2 Fortune 500 companies. ESRD now accounts for 8% of the entire Medicare budget, and we were joking about this. Even Elon Musk has tweeted about the fact that the ESRD program consumes 1% of the entire federal budget. It's over $50 billion. So we've been arguing about the NIH budget, which is only $34 billion, of which $9 billion is indirects. The ESRD program is $50 billion. It's actually over $50 billion. So any argument you make to improve dialysis care is probably not going to go very far if it means that Medicare or the federal government is going to spend more money. So you need to think about that in anything we talk about that. And, of course, one of the things I'm going to talk about is home hemodialysis technology. Technology tends to be expensive when it's first introduced, and then it usually comes down. So how do we get to the point where the new technology is developed when a capitated environment that's $50 billion is not going to have more? And then the other thing that's interesting is when you read all of these other studies that talk about QOL, cost-adjusted quality of life years, they often do efficacy based on what the federal government has been willing to spend to keep a dialysis patient alive for a year. So whether we're talking about a chemotherapy or a cardiology procedure or some other quality of life adjusted year, they typically use the cost of care for a dialysis patient for that. So with that introduction, our goals today are to understand kind of the development of home hemodialysis. I'll briefly discuss the pathophysiology. I've only taken a few slides with that about why we can perhaps manage dialysis care better at home than in the center. We'll discuss the utilization from 2000 onward after we talk about the history, and then we'll briefly just mention some changes that can potentially improve care. So where have we been? So this is Dr. Kolf's rotating drum. Supposedly, there's one of these somewhere in a basement. I've looked now for 6 years to find it. In Indianapolis, there is supposedly one of these there. I don't know if Northwestern has one somewhere in a basement, but they don't throw things away. So Dr. Hamburger and I are on a search for the one in Indiana, and we don't know where it is, but we're gonna look for it, especially since they're tearing our hospitals down in 2 years. We need to find it. Anyway, so he did, in the night 42 to 45, he did 16 patients over that 2.5-year period. And I'm wondering, how this IRB conversation would go today. Dr. Kolf, tell me what you're gonna do. I'm gonna run the patient's blood through this tubing. Well, where are you getting the tubing? Well, I'm gonna go to the butcher, and I'm gonna get the sausage casing, and I'm gonna get very long, and I'm gonna hook it up to this drum. Well, where did you get this tub from? Well, that was from a crashed Messerschmitt fighter jet that landed here close to the hospital, and I'm going to build that. And then where is this pump from? Well, that's from a 1938 Model A Ford that I went and got the water pump out of and do this. And then no animal studies, and of the 16 people, 15 of the people died. Only one person survived their acute renal failure with dialysis. So that's kind of how it started. But then he published this, and he very clearly says, in cases of chronic irreversible uremia, there is in general, no indication for treatment with the artificial kidney. However, temporary aggravation caused by intercurrent infection, diarrhea, or surgery could benefit from dialysis to tide the patient over the critical period. So it's, the initial people who developed dialysis thought this was going to be AKI and not for irreversible kidney disease. But 15 years later, people are starting to use it in that way. So we talk about Dr. Kolf did it in 1942. He moves to the United States and helps develop chronic dialysis. We have a home hemodialysis treatment in 1961 in Japan with a coil dialyzer using an electronic washing machine. We have Dr. Scribner in Seattle using a plate dialyzer, and John Merrill in Boston at Harvard using a coil dialyzer with RN supervision, not at home, in 1960, 1964, and then we have Dr. Sheldon in London does an overnight home hemodialysis treatment. So in the 1960s, we're starting to see this. And these pictures, when you go to your dialysis unit in the other building there and you look at those two machines that you use now and you look at, these are what people used before, and these are often in some of the museums that you might have the opportunity to see, but you can see that these are very complex dialysis operations on people on home dialysis. Other pictures. Now, this is the person below is the first person I met with kidney disease. That's my grandfather. So, oops, where did I go back? And then that's me. Yeah. So this is my grandfather. I think he's 70 in this picture. 2 years later, at the time my parents decide to go on their 7-year delayed honeymoon, and they're in Hawaii. My sister and I get dropped off on my grandparents' farm. And my grandfather at that time, it's late 1960s. I think he would have what we would now consider cardiorenal syndrome, uncontrolled hypertension, a little bit of heart failure from that. He's treated by he's in southern Indiana on the Ohio River, and he's treated by an 80-year-old physician who was trained at WashU in the preflexor time, who did house calls. It's the same person who delivered my mom at home. And he decides to come every day for a while and give my grandfather mercurial diuretics to help treat the heart failure. And my grandfather goes into exactly this. He goes into oliguric acute renal failure, does not recover, and he dies in the hospital about 2 weeks later, just like this is described. There's no dialysis probably in Indiana. There might be in Indiana, maybe at IU, but there is no dialysis anywhere near Evansville, Indiana in 1967. And so he dies of uremia at that time. And so that was my first introduction to that. And sure enough, when you look into this, there's not enough bandwidth to do in-center dialysis everywhere. And so a lot of the time you're going to have to figure out how to do dialysis at home. So the Public Health Service, the predecessor to kind of what we have with the ESRD program now, the NIH and CMS, decides to award contracts for development of center-based dialysis in the United States and home dialysis in the United States. And Methodist Hospital in Indianapolis is one of these. And when you walk into Methodist Hospital, you can see here, in below, this is on the banner, if you walk in the entrance to the hospital, the late George Applegate is the one who did this. And amazingly, over this period of time, he did 3,073 home dialysis treatments, in 1969, based upon this work that was done with the contract. So it's quite amazing. And then in Indiana, over the period of time, you can see even a few years later, in 1977, there's only 8 outpatient hemodialysis centers in the entire state. 8. But there are roughly 700 people on chronic hemodialysis. Roughly half of them are doing it at home. And PD now is not yet available as an outpatient therapy. It's only a temporizing measure for acute PD as an inpatient therapy. Because what requires the development of PD is a stable access and the ability to have stable peritoneal dialysis fluids, which was not available in the 60s and 70s. So then you go a few years later, 1984, now we've gone to 13 outpatient hemodialysis centers. And we still have 203 people on home hemodialysis, but you can see we've gone up to 971 people in those 13 centers on hemodialysis, and now you see CAPD coming. And so this is 1984. We have 540 people on CAPD. Cyclers aren't available yet. Then we go to 1994, and you can see we have 47 outpatient hemodialysis centers. Now we're down to just 40 home hemodialysis patients. We're up to 2,850 in-center patients, 880 CAPD patients, and cyclers are starting to be used. We have 94. And then you go to 2021, which is similar today. I mean, actually, we're a little concerning because we're losing our outpatient hemodialysis centers in the rural areas. They're closing them. But we're at 144 outpatient centers. We have 272 home hemo patients, over 8,000 in-center patients. And you can see we are now 200 CAPD patients, 1,100 CCP patients. So that's kind of what's happened in the state of Indiana. So what happened? So what happened to these numbers to where, this essentially declined, this went way up, and then we have this development. But why did the home hemodialysis go so far down? So one is that the Medicare ESRD program legislation is passed in 1973, which mandates that Medicare cover dialysis based on diagnosis, not age. So when you sign those Medicare 2728 forms, when people start dialysis, you as a physician are certifying that this patient has end-stage, irreversible end-stage renal disease, and they are eligible for the Medicare program, and therefore the dialysis center will get paid. Now, we now have the AKI, which has been added on in the last couple of years, but this is what that 2728. You are certifying as a physician that this person meets the criteria to be enrolled in Medicare, and their dialysis will be covered. Then you also have a payment pathway to develop in-center hemodialysis. And just to give you an idea of what happens when you start to think that, the innovations in hemodialysis happen so much that the payment for a hemodialysis treatment did not increase between 1973 for over 20 years in actual dollars. Now think about the inflation that happened in the 70s and 80s. The payment did not increase. So you developed a payment pathway which allowed the innovation to occur. And so people could now get their dialysis, in the shopping center. And then you also have the development of the outpatient peritoneal dialysis, which basically two innovations. You have the stable access. You have the peritoneal dialysis catheter, and it's evolved a little bit to now we have the double cuffed PD coiled catheter and so forth. But we have the materials and the understanding of the cuffs and the infection rate to get a stable peritoneal dialysis access that does not have to be removed very frequently. And then you get the production of the stable dialysate from the precursor of what eventually became Baxter, which you're all familiar here with in Chicago. And so this is what this looks like. And by the way, so here's the second patient with kidney disease that I meet in my life. That's me. That's my sister. This is my other grandfather. It's my paternal grandfather, who's a farmer outside Kokomo in a small town called Galveston, Indiana. This picture was taken 10 years before he developed ESRD. But he develops this, and he was on peritoneal dialysis. And I was a kid. I was in high school. I didn't think much about it, other than my grandmother has turned into, from being a farmer into being a nurse without a degree, and also a supply management person with all these boxes in the garage and in the house. But his nephrologist is still alive, and actually he goes, "You realize your grandfather was one of the first people in Indiana to ever be on peritoneal dialysis?" I'm like, "Oh, I never knew that." But you can see that PD here starts right about there, 1978 in Indiana, and you can see it goes up to here. And you can see here is home hemodialysis. You can see that it goes here and it goes down. And then you can see the overall percentage of people on home dialysis, PD and hemodialysis, goes from 50% in the 70s to down to about 15 to 18% in 2001. And so that's what happens with that. So that's where we've been. That's how we got to where we are. Where are we now? Well, so then in home hemodialysis, after that 2001 with kind of a steady decline, it reverses. So this is in the United States from 2004 to 2014. You can see we go in the entire country. In 2004, there's only 1,500 people on home hemo, and now we go up to 8,000 in 2014. And we're a little bit higher than that now. It's continuing to increase. We're over 10,000. But what reversed the course? And so why did it reverse over the last 2 decades? Do we have more? And one is the reports of the improved clinical outcomes with longer and more frequent hemodialysis really started this. And they started to come from Canada, predominantly from Dr. Udall, who's no longer living, Dr. Periados, who's no longer living. My understanding is Dr. Quaggan actually trained a little bit with Dr. Periados. But people started to publish various results, and I'll just show you one quick slide that's provocative about that. But the reason that's important to home hemodialysis is practically the only way you can achieve to do more frequent or longer dialysis sessions is to do them in the patient's home. It's a logistical issue, and I'll show you some data that suggests that. Second is there's some emergence of better home hemodialysis technology, which continues this day. So you go from those coil and plate dialyzers that I showed you in the 60s to the standard hemodialysis machines that we used in the 90s, to where now you have various dialysis machines that are designed specifically for home. They're a little bit simpler to use. They're a little bit smaller. They are sort of portable. One company defines portable as, well, it has wheels, so you can push it from one room to the other. The other company says, yes, 74 pounds, you can lift that. Maybe, I don't know, 74 pounds is a lot. But theoretically, it has a travel case. You can check it on a plane. You can throw it in the back seat of your car. So, but it certainly is more portable than the typical machine we use in the center. And then the next thing is that home hemodialysis becomes financially viable. And so you combine all those three things, and you'll see a slight increase in home hemodialysis. And this is published in 2008 by Rob Pauley. And I could show you, again, I've combined about 10 of my talks. We could do a whole talk on the clinical results of home hemodialysis with the various studies and so forth. I'm just showing you a provocative one for the sake of time that does this from 2008, that basically, if you look at it, and again, this isn't a randomized controlled trial, this is database polling. You can see that the results, basically, of the Canadians of nocturnal hemodialysis over a long period of time is equal to, basically, the results of a deceased donor kidney transplant. Provocative, and probably in a randomized trial, I think many of us would think, all things being equal, this may not hold up, but certainly better results than we see for a controlled population on center-based 3 times a week dialysis, where you can see that the nocturnal hemodialysis patients have a 30% mortality at year 9, or a 60% mortality at 60% survival at year 10. And as you all know, our ESRD patients in the United States, the 50% mortality is 5 years. If you're diabetic, it's 3 years. So much better. But there are all kinds of other studies that we could talk about, including correction of sleep apnea, blood pressure control, phosphorus control, metabolic bone disease, and so forth, that are suggested when you do longer and more frequent dialysis. So people are interested in that. Now, as we go forward, what are the reasons to do it? And we'll talk about this. We'll divide it into three areas: logistical, physiological, and then those clinical outcomes. And I'll be the first to admit those clinical outcomes are perhaps not as vigorous as we'd like. They are observational, sometimes anecdotal, retrospective, database. They're really, people have tried to do randomized controlled trials in this. We just have not been able to do one effectively. But we'll talk a little bit about those. And then there's some reasons that are a struggle, or I say not to do home dialysis. But there's some logistical reasons. I won't talk a lot about this. I'll just mention them here. But peritoneal dialysis offers many of the same benefits in a much easier treatment, to the government, a much more financially less expensive way of doing it. Most of the people who see peritoneal dialysis patients would probably agree with me. It's a great therapy until you lose your residual renal function, and then all of a sudden it becomes really dicey in terms of the outcomes. And you can see that in the average time on therapy in the United States for peritoneal dialysis is 14 months. So if you censor death and transplant, 18 months. And the gallows humor that I hear when sometimes I do this talk is somebody will raise their hand and say, yes, but it's the best 18 months of your life. So that's kind of the joke about it. But it's not a long-term therapy. So people lose their residual renal function. I think PD is a great place to start. They lose their residual renal function. They haven't been transplanted yet because it's a 5-year wait. So what do? You have a choice between in-center hemodialysis or home hemodialysis. 4 to 6 weeks of training is typically what most people describe with home hemodialysis. We talked about this morning with the nurses. One of your colleagues is going to have a Shark Tank proposal to fix this. I'm looking forward to it. Is that the majority of patients need a caregiver. And that is absolutely true. And if you look at if you consider PD patients and home hemodialysis patients kind of the same group of patients, they have the same twinkle in their eye. That's kind of how I describe it. In other words, I'm willing to take care of myself. I have family support at home. I'm willing to learn. Let's go. So the difference is the PD patients drop off of PD for medical reasons, by and large. The reason people drop off of home hemodialysis are what we put into the psychosocial bucket, or we say burnout. And it's either patient or caregiver burnout. So I look forward to the Shark Tank proposal because the majority of patients right now, with the complexity of home hemodialysis and the way we do it, need somebody to help them, which is usually a family member. And I almost think I shouldn't probably go here, but the interesting thing from the database is, are there more men or women in the United States on home hemodialysis? Anyone? One of the fellows. Guess. You got a 50% chance of being right. What? Men. Okay, so why? Tell me why. There's no data on it, so this is just all opinion. Why are there more men on home hemodialysis? There aren't more men on hemodialysis. There are more women on in-center hemodialysis. PD is about 50-50. So why are there more men on home hemodialysis? Yes, exactly. No one's done that study. Somebody should do that study. I'm absolutely sure, because the women are willing to take care of their husbands, and the husbands are saying, no way. Right? Not all husbands. That's why I probably shouldn't have gone there. Now I'm in trouble. Anyways, it's an interesting phenomenon, but to the point is it requires a caregiver. And then the supply, delivery, and storage can be a little bit cumbersome. And then you also have to deal with, you have to deal with water in the patient's house, which can sometimes be an issue. And then, we can talk about trash. In rural areas, believe it or not, in both Missouri and Indiana, some people still burn their trash. So in Missouri, I had one person say, Dr. Miller, it's like we're not sure what to do. We tried burning the supplies from the home hemo machine, and it just turned into this massive black cloud of smoke. Hadn't thought of that problem before. So they had to hire a trash service to come, in a rural area. So they have to hire a trash service to come and pick up their dialysis waste because of that. Adverse events, and there are two. Basically, two. One's infection, and one are the mechanical complications, which both of those almost always track back to the vascular access. So if you want to know how can we prevent problems in your home hemodialysis, really work hard on the vascular access, and then operator error. I used to show this slide. This was published in 2013, and people would kind of roll their eyes because I became interested in this because several of my colleagues internationally were talking about what Sears and MERS did in their dialysis centers in Asia back before 2010 and right about 2010. Those are coronaviruses. I had no idea what a coronavirus was. So anyway, I would show this, I would talk about this because when I'd been talking to my international colleagues, and they've been talking about Sears and MERS being a problem with dialysis patients in Asia, and finally, this comes out in the New England Journal, so it's like, oh, that's what all my people in Asia have been talking about. I'm going to read about it. And so I pull this out, and it's in the supplementary part. Dr. Roddy, we were talking about people, the fellows often don't read the innards of articles this morning, weren't we? This is an example of why you should read the innards of articles. They totally mistitled this. This isn't a hospital outbreak. This is a dialysis outbreak of coronavirus. So what happened is the incident patient, they had 2 patients in the whole city, I forget where this was, that had the MERS. You know, I think this was the U.S., so it's like not too many of us got MERS. Okay, the one who contributed to the incident patient A, you can see he's here. Patient C, who's in the bed next to him before they diagnosed MERS, is a chronic dialysis patient. Patient C then goes to the inpatient dialysis center and the outpatient dialysis center, and all the purple people are chronic dialysis patients. And then the people beyond that are the family members of all the dialysis patients. This was a dialysis outbreak of coronavirus. Now all of a sudden people are like, oh, I know what a coronavirus is. But so it's like it gets overwhelmed by that. But by not going in center, you don't have exposure to the healthcare environment, and this makes it very nicely. You also had the flexibility, and these are my patients, and they've allowed me to show these pictures, and it's a little bit provocative perhaps, but these are 2 of my patients. Both this patient had to wait a little while for a transplant. PD failed. This patient also had PD fail for various reasons and had a high PRA. They're both transplanted now, but they needed an extended period of time on dialysis because of other issues that they couldn't do PD. And they went to home hemo, and you can see that they were able to do things. This one's on a cruise ship on the right. This one's ziplining, I think, in Colorado with his family, and he took his machine with him. Lastly, this is from Dr. Ting in California. I believe he's retired now, but he tried very, very hard. He took some people, I believe, within the Kaiser system where they're very cost effective. And he said, I'm going to take some of your people that have heart failure or have recurrent volume overload in the emergency room because it's one payer and they have this. And he says, I'm going to keep them out of the emergency room by dialyzing them more frequently. And they said, fine. So he did that, but the problem was he was in a 32-station, 180-patient outpatient center. And so he identified 40 of those patients that were either had heart failure or were overutilizing the emergency room for volume overload. And he tried dialyzing them more. And you can see with each time he added a treatment to 40 patients, he lost dialysis chairs. So we, at least in Central Indiana, have a shortage of outpatient dialysis chairs. So trying to go to a LDO and say, like, listen, we would like to take a percentage of these patients and do them 4 times a week, maybe 5 or even 6, we're going to lose dialysis chairs. And it's the same staff, it's the same electricity, it's the same water. The costs are staying the same. Your fixed capital costs are staying the same. And you may get reimbursement for the 4th treatment if you justify it, but you're going to lose chairs. You're going to lose spots where people could come and do 3 times a week. So that's what I mean. If you're an argument that you want to eliminate the 2-day gap, as I'm going to show you, you're going to have to be an advocate for home dialysis. You can't do it in today's world in an in-center environment for very many people. Secondly, what about more time? So this is an NIH trial that didn't go well. It's called the TIME trial. And it was a pragmatic trial, and we could talk about some other issues, again, longer talk, but they randomized patients per unit incident patients to usual care or 4.25 hours or more of dialysis 3 times a week. They had to stop this study because the patients who were supposed to do 4 hours and 25 minutes did 3.5. So they only got 9 minutes of separation between the patients. So they stopped the study because you can't base that on 9 minutes. The point being is people may be willing to dialyze longer or more frequent at home. They're probably not willing over the long term to dialyze longer in center. And you can see people said, I'm going to do 3.5 hours. Now with dialysis, now let's talk a little bit about the physiology. So let's go to the physiology of how you would manage home dialysis. So we're trying to replicate this filtration barrier with this, a semi-permeable membrane, mostly made out of polysulfone today. The way they make that is they take polysulfone beads, which looks like a little plastic ball. They heat it up. They extrude it over a titanium point. It forms, as it dries, it forms this hollow fiber that has these membranes like this. And it's a little bit like I got told when I would visit the farm, and I'd be fooling around, and they'd be harvesting, and you'd see the corn come out of the chute, and when me and my cousins were like fooling around or making cracks, so we get told like, every dollar that this family spends comes right out of that chute. Everything that we do in dialysis goes through these membranes. So that's our limitation. And the way these membranes dry, they're not straight membranes. They dry as the polysulfone cools, as it is extruded over this cone. It dries into channels like this. And so you have different ways that the small molecules and the large molecules are going to come across. It's not a straight shot. And then you have to ask, well, what am I trying to remove with the polysulfone membrane? And you have all these things. There are a lot of people, Tim Meyer, Tom Hofstadler, have written very good pieces about that. There are all kinds of different things that we are trying to remove. What causes uremic syndrome? What can we remove? What causes it? How can we remove it better? It's still up for debate. This was an ASN poster that was one of the coolest ASN posters I've ever seen. I just happened to walk by it. I don't think it was ever published. But what they did is they did pre and post breathalyzer tests on patients, which I thought was a cool way to, instead of drawing blood KTVs, we should walk around and you can't, just like you can't start your car, if you've had a DUI, you have to blow into that and your car will start. We should not let them off the dialysis machine until they pass the breathalyzer test. But when your kidneys can't get rid of organic volatile compounds, your lungs help out. And so the reason that our kidney patients that are uremic and underdialyzed have the fetor of uremia, similar to the liver failure patients that have the fetor, the bad breath, the halitosis of liver failure, is because their lungs now are excreting volatile organic compounds that their kidney or their liver would have normally gotten rid of. And so it's interesting, right? It's like we don't talk about, well, how much isoprene did I remove with last night's PD cycle? There's all these things that we don't think about. And are they important? I don't know. But it would make sense that, because the way that we measure dialysis now typically is up here with these small water-soluble molecules. I tried to draw this cartoon just to demonstrate the difference in relative size based on their molecular weight. How they act in solution also is different, right? Because some are protein-bound. Phosphorus is a charged molecule that is surrounded by calcium that does it because of the Gibbs-Donan effect, doesn't come right across the semi-permeable membrane like it would based on its size. And then you have these larger molecules. So the point of that is we don't really know what we're doing. We have surrogates for what we think is effective or what we sometimes call adequate dialysis. We have no idea what the optimum is. I want to show 2 slides for the fellows that when you think about doing dialysis in the home are important to realize. These also have relevance for PD, but I'm not going to talk about that. Because what you see on your in-center rounds and what you see in the acute dialysis center, the reason you are doing things with high dialysate flow and the way you do it is to make the treatment as efficient as possible for time. Not for clinical outcomes, for time. That's why what your prescription does. I'm not saying there's anything wrong with that. I'm just saying that's what you're doing. So when you move to a patient's home, though, the labor costs, the time costs, those things are there's a labor cost of the person, but they're not paying it in cash. There's a time cost certainly, but they're not having to drive and sit in a unit and miss something. They're at home. So you can manipulate the treatment according to what you want to do. So I'm going to show two things. I'm going to show this slide, which what is the solute removal based upon a constant dialysate volume. So this is telling you the effect of hemodialysis time upon solute removal. So this is an 84-liter treatment that was done in the same patients, 4 hours, 6 hours, and 8 hours. And look at the percent increase over the 4-hour treatment of the 6 and 8 hour treatment. So you can see that the small molecules increase 7 and 25%, 20 and 35%. Phosphorus goes 25 and 40%. But the larger molecule, beta-2 microglobulin, is almost linearly increased. So for the point being is that for many of these larger uremic solutes, time is more important than your dialysate flow within the physiologic range. The same thing is true on PD. So a mistake that people often make because the patients don't want to do it is they let people have a day dwell dry. When people start to lose their residual renal function, the biggest bang for your buck in PD is the day dwell. Okay, now we're going to flip to another study. This is, yes?
You remember, I'm sure, this unit in Nice, France.
Yes, the Tassan experience.
Dialyzed people show up and they have the best results in terms of mortality.
And I have a talk that, I didn't include that study in there, but yes, he's absolutely right.
Nobody perhaps wants to do that 8 hours a day.
Not in the center, but probably at home, we could maybe talk about people doing that. So now we're going to look at the opposite, is that we're going to keep time constant and increase the dialysate flow in hemodialysis. And you can see that you get a significant increase in urea, an increase in phosphorus, and no increase in beta-2 microglobulin. So some uremic molecules are very, very, very time dependent, and some are both time dependent, and you can also increase the clearance just by increasing the dialysate flow, the amount of dialysate you use in a period of time. The reason I bring this up is like, even I get caught on this. You see somebody in the unit that keeps having a high phosphorus, high phosphorus, high phosphorus. And, I'm prescribing my 18th pill of Sevelamer with the dietitian. Instead of thinking like, gee, even though their KT over V is okay, maybe I should increase their dialysis time. Because when you increase their dialysis time, you get a bump in phosphorus clearance. Anyway, this is important because one of the most difficult things to do in home hemodialysis with the way we currently do it is produce dialysate in the patient's home. So if you understand this, you realize that you can use less dialysate in the patient's home, which makes it more cost effective and easier to do and get adequate results. Lastly, I want you to think about how we measure this. So for the fellows, do this exercise sometime. Measure your own weekly KT over V. Sit down and figure out how to do it. It's not that hard. It's like measuring a 24-hour urine creatinine clearance. But if you look at what the average hemo patient's KT or weekly KT over V is, it's 2.3. PD is like 1.7, 1.8. Yours should be between 20 and 25, hopefully. That's where you should be as a healthy person. So is it any surprise then that we get results like the hemo study, which was one of the better nephrology studies that was done, NIH study, 1,800 patients, 5 years, 15 U.S. centers, 44% diabetics. Most of the patients were anuric. People were randomized to a high-dose KTV or low-dose KTV, but there was only 29 minutes of different time. So basically, you only increased the weekly KTV by, about 0.3. So is it any surprise that you can see if you're only increasing this by 10%, that you would, why would we expect that to have a big difference? And urea is a small molecule. So and this is where, it's like even with home hemodialysis, I can only get this up. Even with 6 sessions a week, I can only get this KT over V weekly up to about 4. So that's why this isn't a perfect answer. That's why everyone needs to move towards kidney transplant, maybe pig kidneys. But, it's better, but it's not perfect. Here's where the hemo study was. Here's if you do 6 sessions, 6 sessions a week, and you get an EKT review of this, you can get to a weekly KT review of 4. Now, what about a designer? So maybe we shouldn't be thinking about urea so much or creatinine so much. What about if we design dialysis more around electrolyte, salt, and water removal? And I would encourage you, maybe we should start thinking about that a little bit more. And this is where the opportunity for home hemodialysis to really shine is, because you can better improve your removal of salt, water, and electrolytes. This study now has been done several times. So this is the Rob Foley study. Took 30,000 U.S. patients and looked what day they died on. And by and large, they died on the first dialysis. There's a marked increase in death, predominantly from cardiac causes, on the first dialysis day of the week. So for the Monday, Wednesday, Friday people, that's Monday. That's basically Sunday afternoon through the first 12 hours after the Monday treatment. For TTS people, it's Monday afternoon to the first 12 hours after the TTS. So if Medicare asked me, what's the one thing you could do to improve dialysis outcomes in the United States, one of the answers I would give you is, let's not have a 2-day skip. Can we do every other day dialysis instead of 2-2-3? That would be my first answer, because you would think that if we kept the dialysis units open on Sunday, we might be able to do that. But this has been repeated. So, Rob Blyer noticed it. He did 2 studies on it, 99, and then the one I'll show you in 2006. It was done in Europe, in Japan, and the U.S. with DOPS. It was done with a UK database with 5,000 people, and it was done with 14,000 people in Australia and New Zealand. And interestingly, if you look at transplant patients, home hemo patients that don't have a 2-day skip, and PD patients, they don't have a bump up in that cardiac mortality or that overall mortality on the 2-day skip. I think that's all due to salt and water. That has nothing to do with urea clearance. That's all potassium, salt, and water. So Tony Blyer from Wake Forest then, because Wake Forest has basically a statewide dialysis population that their doctors manage and own, they're able to identify this. So he took a bunch of their patients who had witnessed cardiac sudden death in their system, and he took the dialysis records and he looked, when was from their last dialysis did the patient die? And you can see that the risk factor is in the first 12 hours after their last dialysis, and then once you get beyond 2 days or more of dialysis. So again, in my mind, if we wanted to do the public policy thing, I would say is can we eliminate this? Second, how you remove the salt and water matters. So this is just a nice study that was done. The UF correlates with your cardiac stunning, and you can see for every ultrafiltration volume, for every liter, your relative risk of cardiac stunning goes up 2.54. Here's cerebral blood flow. So this is cerebral blood flow. So as you do more UF during the dialysis, your cerebral blood flow goes down. Here's renal blood flow. So again, and this one is a little bit scary because this is Chris McIntyre's group. Their UF rate was really low, 6.7 milliliters per kilogram per hour. But yet you see the change in renal perfusion as it correlates with the ultrafiltration rate. And you can see the number of stunned segments. Then he also measured the stunning of the myocardium on this axis. So if you're wondering why hemodialysis patients lose residual renal function quicker than PD patients, this is probably it. Because every time you're doing a treatment, you're causing a little bit of renal ischemia. So then we go to, okay, let's try to reduce this. So this is the FHN study, which was 247 patients randomized to 1 year to in-center 6 times a week treatments for a maximum of 2 hours and 45 minutes, or usual care of 3 times a week. Interestingly, again, why home is better, the 6 times a week people showed up 5 times a week. So even though it's which I probably would too, I had 10 patients in this study in St. Louis. It's like, and they all told me that. It's like, I'm not coming 6 times. It's like, and they didn't. They came 5. So this is 3 versus 5. And so this is the way Glenn Chertow drew this graph. You can see there's a start in separation in mortality at the end of 1 year. However, because it's 247 patients in 1 year, the separation, it's not significant, but then we combined it. My understanding is this is the first time the NIH ever did a study where they had a combined a heart outcome and surrogate mortality. So this was a little bit of, grantsmanship, I guess. I don't know what I'd call it. But then you combine the people who are alive and you looked at what their LVH was by MRI. Because believe it or not, the NIH epidemiologist said, you ask them, well, what's the best marker for mortality in a SRD patient? And I was like, that's an interesting question. The NIH epidemiologist during the study said it's LVH. I'm like, really? So that's why we did that. And you can see that the frequent dialysis, they had a better LVH. And so based upon that, we came up with, if you use this as a surrogate marker, the hazard ratio for mortality is 0.61. So the idea that you do 5 times a week dialysis versus 3 times a week dialysis is a 39% improvement in mortality. You have to you have to believe kind of the surrogate outcome and so forth, but it's there. So then, a couple years later, we look at the 5-year follow-up of people in the FHN study, and sure enough, the people who were on more frequent. Now, the interesting thing is, most of these people went back to 3 times a week in center. A few of these people chose to do more frequent dialysis at home. A few. And not the data wasn't all clear on that, but you can see just the people who were randomized initially to frequent dialysis, some of whom only did frequent dialysis for a year, some of whom continued, their mortality benefit was better, and even if you censored it for kidney transplant, their mortality still stayed better. But interestingly, if you look at the sub-analysis, and this gets back to my original point, I think you could make an argument that the reason that this is potentially better has nothing to do with the clearance. It has everything to do with control of your salt, water, and electrolytes and how you do the dialysis, and you're taking off less fluid at each time of dialysis. That's what I think. And this is the subgroup. So you can see blood pressure, much better controlled. Phosphorus, much better controlled. The LV mass, much better controlled. Why is that? Because we're not stretching the myocardium by people gaining 2, 3, 4, 5 kilograms on their 2-day skip. Their physical health was... What? Yes, there is. And so the problem, though, is people adjusted the potassium bath to account for the more frequent dialysis. So it's not very... What data would you like to see? It's about the same. I'll have to pull that out. But what happened was people adjusted the pre-dialysis, they adjusted the bath from a 2K to a 3K. So it's a moving target. But I haven't looked that up for 10 years. But that's a good question. I'll go back and look. Then also, we talked about salt and water. What about symptoms? And this is Bob Lindsay's results from Canada. This has been done by other people too. So this is one of the older ones. They basically just asked these people. Some people were on daily hemodialysis at home. Some people were on nocturnal hemodialysis at home. And the control group is in-center hemodialysis 3 times a week. How long does it take you to feel like doing the things you were doing before you started the dialysis treatment? So recovery time. If you talk to in-center patients and you ask them, when do you feel the best? It's usually the day, and it's right before dialysis again. They say, I'm kind of washed out the day of dialysis. I start to feel better the next morning, and then by afternoon, I feel pretty good. And the next morning, I feel great. And then all of a sudden, I go back to dialysis, and I start the cycle again. And sure enough, that's what it says. The mean times to recovery by patients, in-center 3 times a week dialysis, 7.3 hours. Daily home hemodialysis, 0.6. And by daily, we mean 5 to 6 times a week. Nocturnal hemodialysis, 5 to 6 times a week. It takes me 15 minutes to feel like I did before. So that's kind of my compressed 25 years of data and talks into that. Hopefully I didn't confuse everyone to go through it. Where are we now? And so I think, and we had this discussion in the dialysis unit this morning, if we're going to improve this, we have to address the problems. And so what are the clinical problems? Vascular access, infection, ease of use of machine. the training of nephrologists. We don't train people very well in this. Patient burnout. And then if you talk to Dr. Lockridge, he's retired now in Virginia, but he had a long 25-year cohort of dialysis patients. People did well, but when they had a severe physical or cognitive decline, they couldn't be maintained at home. You have logistical, the need for the care partner, the training time, the supplies. You're very fortunate to have the nurses you have here. I don't know if you realize that. You're extremely fortunate to have the nurses you have here. You should all thank them. You know, I won't say anything more. You can come spend some time with me and I'll show you what I mean. And then the economic. It's hard to innovate in a capitated environment. That's the world we live in. Everyone here has been willing to pay $1,000 every 3 years for a phone. You know, no one here is probably willing to dole out $106,000 a year for dialysis. You know, it'd be hard to come up with. And then there's this, people don't like talking about this, but there is a massive capital investment in in-center hemodialysis in the United States. So every time you drive by a McDonald's, every time you drive by 2 McDonald's, you've driven by a dialysis center. So think about that. There's 13,000 McDonald's, there's 13,000 Starbucks, there's 7,000 outpatient dialysis centers. So think about that. I mean, I think about that driving here, I'll drive home. It's like I drove by a lot of McDonald's. I probably drove by a lot of dialysis centers. So that's a huge capital investment. So to get people to change that capital investment is going to be hard. So here's an example. I only have 5 minutes left. So access. You know, there's all these problems. You know, if you have these problems, you should probably really look at it in a QI process. For the sake of time, I won't do this. What we've worked on in St. Louis and Indianapolis is working through the process of cannulation. If you ask your in-center patients, why don't you do this at home, this will probably come up as I don't want to have to stick myself. There's a process to doing that. It's in the CMS regulations. If anyone ever pushes back at you on the in-centers that we don't have people to train your patients to do cannulation, can't do that. CMS has said that to be certified as a dialysis in the United States, you have to be willing to train in-center patients on all aspects of their dialysis care. The patients, believe it or not, do what the nurses do. So this was a neat study where they looked and see if the nurses broke training quietly, and then somebody observing, and they saw if the patients then subsequently broke training, yes, no surprise, linear relationship. So that's an example of if we can fundamentally drill down, root cause analysis, and fix some of the problems, we can have outcomes. So where are we going? Here are what I think the advances we need. We need smaller and lighter machines. We have to figure out, and more reliable, better dialysate preparation. I think there's a tremendous opportunity with whatever you call connected health, monitoring, and so forth. We are close to having measurement of mass balance during a dialysis treatment. You can do it in a lab. So that, in other words, instead of me prescribing a dialysate bath, I can set the machine, remove X amount of potassium. That's a very pertinent question. How much potassium do you want removed today, doctor, on this dialysis treatment? Understanding uremia better, and I'm hoping the proteomics and the other things will help us on that. Better training techniques, and we need more nurses and more nephrologists well-versed in home hemodialysis, which you're doing here. Again, you're fortunate. You don't realize how fortunate you are. PD, same thing. And I think most importantly, people need to realize we as a country are running out of the resources to provide outpatient dialysis. So it's not going to look like this much longer, which can be solved. So just as an example, we're working on this with ASN to improve fellow training. You're very fortunate here. You have it in-house. Most programs do not. We're working on using some of the resources for vascular access. This is Shauna McMichael. She's my nurse from St. Louis. We bought an ultrasound machine. We trained the nurses how to do it, and all of a sudden they use it during their home access training. As we get to the point where people my age, I wasted way too much time on video games. So I understand if you show me this, it's like, okay, stick this here. The new generation of dialysis patients, because they were like me, they wasted way too much of their adolescence on video games. They understand if you show them a picture that the needle goes here. This is Dr. Vesley. He's doing it, figuring out a problem. Technology, this is where, there's benefits and nots. Here's some, I just show you, these are 3 machines that were great technology. One made it. Outset Tableau made it. It started out as Home Dialysis Plus. It made it. It's limping along a little bit. But these other 2 were great technology, and they're on the shelf. They're FDA approved. They're on the shelf. One is sorbent-based, and then one is not. But they've been shelved. This is what we have now that's FDA approved. So, we're getting there. So in summary, home hemodialysis is not new. It's been done for over 60 years. We need to, if we're going to improve home hemodialysis, we have to understand hemodialysis better. My opinion for the younger faculty and the fellows, if you want to do hemodialysis and home hemodialysis better, figure out salt and water and electrolytes. I think that's your biggest opportunity for improvement. We need better technology. It can be developed. It's there. We just have to get it to market. And then this is the hardest, right? Change is hard. How do we change the built-in entrenched behaviors? That is hard. And we may have to be forced to do that. So thank you so much for inviting me. Thanks for the hospitality today. And email me anytime. And I have 2 minutes for questions. Yes.